Welcome back to our Explainer series on vestibular paroxysmia. We've already covered the history, the mechanism, and the diagnostic criteria. So in part 5, we're transitioning right into clinical application. We're focusing purely on management today. How do we actually treat this incredibly fascinating yet completely debilitating condition? We're going to explore the exact pharmacotherapy and surgical interventions you can use to effectively give these patients their lives back.
5-6 video, Vestibular Paroxysmia, Management, Pharmacotherapy, and Microvascular Decompression, Vestibular Physician. Think about it. How often in the field of neuro-otology do you find a chronic vertigo syndrome that can be almost totally shut down by a simple low-dose tablet? It's incredibly rare. But with vestibular paroxysmia, that's exactly what we have. It is an absolute joy in clinical practice to see how appropriate medical therapy can abolish roughly 90% of attacks in these patients. It's a genuine magic bullet, and mastering how to safely deliver it is the entire core of our explainer today.
Okay, let's dive into this. Our clinical funnel today covers our overall management paradigm, first-line pharmacotherapy, the VESPA trial, second-line agents, microvascular decompression surgery, and finally, secondary vestibular paroxysmia.
Starting with Part 1, an overview of the management paradigm. In short, we rely on a highly structured combination of symptomatic pharmacotherapy, supportive care, and patient education, keeping surgery strictly in our back pocket as a last resort. Let's move into Part 2, first-line pharmacotherapy. This is the bedrock of medical management. Because vestibular paroxysmia is essentially the eighth cranial nerve's version of trigeminal neuralgia, the fundamental mechanism is an electrical short circuit caused by focal demyelination, right? Therefore, the absolute core of our treatment relies on sodium channel blockers. They stabilize the inactivated state of voltage-gated sodium channels in those demyelinated axons, which effectively shuts down the ectopic firing. So the crucial point is to start low and go slow, and confirm with a diary. Because these attacks are so brief, a patient's daily attack diary becomes your most powerful tool. If a patient's dozens of daily attacks suddenly vanish on a very low dose of a sodium channel blocker, well, that rapid relief practically secures the diagnosis for you. When we look at our primary interventions, we're really contrasting carbamazepine and oxcarbazepine. Both of these are incredibly effective at doses way below what you'd use for epilepsy. For example, relief is often achieved at just 300 to 400 milligrams a day for carbamazepine. But as a clinician, you have to navigate their differing side effect profiles. Carbamazepine is a potent enzyme inducer with numerous drug interactions, so it requires full blood count and sodium monitoring. Oxcarbazepine is a brilliant equivalent first-line option with far fewer drug interactions, but it carries a significant risk of hyponatremia, so monitoring serum sodium remains absolutely vital. Moving to Part 3, the VESPA trial. This is our definitive evidence base.
The VSP trial is monumental because it stands as the only randomized, double-blind, placebo-controlled crossover trial we have for vestibular paroxysmia. It definitively confirmed the efficacy of oxcarbazepine, showing a marked, significant drop in attack frequency compared to the placebo. But it also did us a huge favor by formally flagging the tolerability issues. While it cemented oxcarbazepine's status as a first-line drug, it clearly proved that side effects like dizziness, fatigue, and asymptomatic hyponatremia are really common, which means we have to stay highly vigilant.
Now, what's really interesting about this slide is how highly specific these dosing targets are when translating the evidence into daily practice. Carbamazepine starts at 100 milligrams twice daily, and we're aiming for 300 to 800 milligrams a day. Oxcarbazepine starts around 150 to 300 milligrams a day, titrating up to 600 to 900. We also have lacosamide emerging as a fantastic option, starting at 50 milligrams twice daily. Plus, there's a very specific weight-based strategy for those rare pediatric cases. Let's move to and see how this builds directly into the 4 to 6 week therapeutic trial workflow. You start low, titrate using that daily diary, and make your real assessment at the 4 to 6 week mark. Partial responders get a dose escalation, assuming they're tolerating it well. But listen, there is a vital clinical warning here. If a patient is having persistent attacks at the maximum tolerated dose, you need to switch the agent or the class. Do not just endlessly push those doses higher. If it's not working at the top end of the therapeutic range, it is time to step back and reconsider your diagnosis.
Part 4, Second-line agents and supportive care.
When first-line options just aren't viable, lacosamide serves as a fantastic emerging second-line agent. You do still need to monitor serum sodium, especially in older patients, and definitely watch the PR interval on an ECG. Now, in our special pediatric populations, the strategy is pretty unique.
We use a very low weight-based dose of carbamazepine for 1 to 2 years, and then we actively attempt withdrawal. Why? Because a child's skull is growing, the structural relationships are changing, and the offending vascular loop might actually literally shift away from the nerve, resolving the condition entirely on its own.
Never underestimate the power of supportive care. In this specific realm, education is highly therapeutic. Look, having dozens of sudden, unpredictable spinning attacks every single day is absolutely terrifying. Taking the time to reassure your patients that their condition is completely benign and highly treatable fundamentally relieves their anxiety, and that is a critical part of the cure. Add in some temporary driving precautions and structured follow-ups, and you've provided a really comprehensive safety net. Keep in mind, vestibular rehab is generally not for the paroxysms themselves. It's strictly reserved for patients who have developed a residual, persistent baseline deficit between their attacks.
Moving to Part 5, Microvascular Decompression Surgery, the absolute definitive last resort. Anatomically, down in the cerebellopontine angle, the anterior-inferior cerebellar artery courses right up against the cranial nerves. And this brilliantly illustrates the surgical reality. Microvascular decompression, or MVD, involves a retrosigmoid craniotomy. The neurosurgeon goes in, carefully identifies this offending vascular loop, and physically separates the vessel from the vestibular cochlear nerve. Typically, they insert a tiny piece of Teflon sponge between them to permanently halt that pulsatile compression. The outcomes for MVD can actually be spectacular. We're talking 70 to 80% of patients achieving complete or near-complete symptom relief, particularly when advanced imaging has clearly identified the offending loop beforehand. But we have to authoritatively weigh that success against the brutal reality of the procedure. Operating deep in the posterior fossa carries severe risks: permanent unilateral hearing loss, facial nerve weakness, and rarely devastating cerebellar or brainstem infarction. This is exactly why MVD is a genuine last resort, reserved strictly for cases that are entirely refractory to medical management.
Let's quickly hit Part 6, Secondary Vestibular Paroxysmia.
If a high-resolution MRI reveals that the neurovascular cross-compression is actually being driven by a structural mass, like an intracanalicular vestibular schwannoma, a meningioma, an arachnoid cyst, or maybe even extreme bony narrowing of the internal auditory canal, the entire treatment paradigm completely shifts. You are no longer just managing symptoms with a daily pill. Your primary objective immediately becomes addressing that underlying structural lesion directly with the appropriate surgical or oncological teams. We've covered a massive amount of ground today, from the incredible efficacy of sodium channel blockers to the really intricate risks of microvascular decompression. But all of this leaves us with the provocative final thought. If a simple low-dose pill can essentially cure 90% of the attacks, what does that actually mean for the patient 10 or 20 years down the line? How do we navigate the long-term prognosis, the potential for recurrence, and the lingering controversy surrounding a condition that usually requires lifelong medical therapy? In Video 6, the final episode, we cover prognosis, the major controversies, and future directions. Visit AustralianDizzinessClinics.com for the full literature review and clinical resources.